Welcome to AAMG YouTube channel. Today we're very fortunate to have our AAMG internal medicine doctor, Dr. Hans Yu. Dr. Yu, how are you?
Very good, thank you, Esther.
Yeah, Dr. Yu will come in and talk about depression, the topic of depression. So a lot of people would like to know more about this, especially during this time. So Dr. Yu, could you actually, as an internal medicine, could you explain to us what qualifies you to talk about this topic? And maybe introduce your practice to us as well.
I'm so happy to be able to discuss this so important topic in depression. And first of all, I'm an internal medicine. I'm an internist. I deal with a lot of patients in many illnesses. And I'm not a psychiatrist, so I'm not really trained in psychology. But in my practice, because we see primary care, we see a lot of patients coming in, and especially around this time of pandemic and post-pandemic, we have a lot of people coming in have all kinds of symptoms where may be related to depressions. And so over the past, I would say 28 years, we do see a lot of patients with depressive symptoms. And we are the primary, we are the first one that they will come to us to seek help. And we try to make the diagnosis, do all the initial workup, and then we'll determine if the patient needed to refer to a psychiatrist or a psychologist for further evaluation and treatment. Today, I just want to talk about some statistic about depression in the United States. And these data are from 2017 and 2018. I'm sure the data may be updated more recently. In the United States, 7.1% of the population have some sort of depression. In my opinion, this percentage is probably low because a lot of patients who are having depressed mood or depression may not seek help. And overall, with all depression, about 8.7% of them are female and 5.3% are male. So there seems to be more dominant in female population in male population. And the common age of diagnosis, the age of 18 and 25 are the most common. It's quoted as about 13.1%. And 50 to 50-year-olds or older is about 4.7%. And again, I think that percentage of the seniors are estimated in a low range. I think most seniors are depressed, but they don't express it. They don't want to show their feeling. And often I think they hide their depression. And if you look at overall treatment in the United States, all patients with depression, only 6% are on medication. About 15% are on psychotherapy. There's different types of psychotherapy, and we'll talk about it later on the talks. And in combination of medication and psychotherapy, it's about 44%. But I like to point out there's 35%. That's quite a piece of a pie that are not treated for clinical depression. Now, the treatment of depression actually is very successful. The successful rate is about 80 to 90% that will respond to either medication therapy or psychotherapy or a combination of both. The cause of depression, you can break it down into four major areas. One is environmental, such as situation. Pandemic causes a lot of depression. We're sheltered in place. We don't get to socialize with friends. Those are environmental, something we are out of control. Flood, fire, major fire causes loss of lives, loss of property. Those are environmental, can cause depressions. Biological is something, is another disease, another condition that causes depression, such as hypothyroid, maybe certain hormone deficiency, vitamin deficiency, or brain tumor, certain thing that can biologically cause depression. And then psychological. There are people who, under a lot of stress, anxiety, maybe previous childhood history of abuse, physical and emotional abuse, so they can present with psychological depression. And then finally, genetic. We know genetic play a major role in depression. We found 40% of the patients who have family history of depression, they will get depression. So 40% is almost 50%. That's quite high. And also when we look at twins that have depression, if one twin has it, 70% chance the other twins also will have depression. So we know there's a genetic factor to that. one of the risks I mentioned about genetic, right? So family history. If you know of that family, when you take a family history of that patient and know that there's depression, mom had depression, father had depression, or whatnot, the chances for this patient presented with depression is pretty high, 40% chance. And patient who had history of depression. I saw somebody who back in high school, she had depression. Now she's in her 40s and she come back with depression due to a loss of a job, due to loss of a relationship. And major life changes will be a risk factor. If suddenly your job is gone or you lost your restaurant because of the pandemic, so those will be a risk factor. And then, as I mentioned earlier, physical or emotional trauma, abuse when they were young. There's some event happen in life, in early childhood, or late on in life, it can cause depression. And then stress and anxiety is another risk factor. And then physical illnesses. A lot of patients who are, let's say, recently diagnosed with cancer or maybe diagnosed with some sort of serious illnesses, and they can put them into a higher risk of depression. And finally, medication. About 2 to 3% of depression are due to medicine. One of the common medicine that can cause depression when used high dose is beta blocker. It's well known in the medical literature that can cause depression.
Thank you, Dr. Yu, for giving us an overview. So could you actually tell us a little bit more about how people first start having the medication? Would you prescribe the medication to patient as interim medicine? How's that work?
Yeah, we do oftentimes use antidepressant to help patient, but before we can really start patient on medicine, of course, we have to make the diagnosis, and we have to learn about the patient a little bit more, get a family history to see if they have family history of depression. And first of all, when they come in to see me, I want to determine what's going on. Insomnia, not able to sleep. They come in presented loss of weight, or not feeling well, feel tired, feel fatigued. So we oftentimes will investigate a little bit. There's certain tools that we can use to determine if the patient is depressed or not. There's a common tool that's used by most physicians is called the PHQ-9, which go through 9 questions to the patient, and the patient answer. If that happened to them every day, sometime of the week, for the last 2 weeks. If they do, we calculate a score, and that score to determine what are the risks for this patient of depression. What are the questions that we ask? These questions actually is a sign and symptoms of depression. So one of the questions that we ask, number one, is do they have very little interest or pleasure in doing things? When don't feel like doing things. Let's say if they love to play basketball, for whatever reason they're not. Or they like to play video games. For now, they don't even touch video games anymore. So that's loss of interest and loss of pleasure in doing things. The second question we also ask, do they feel sad? Do they feel down? Do they feel hopelessness? Some patients will say, I just feel so bad. I feel sad all the time. I just feel like the world is hopeless. There's nothing in the future. So these are the clues that we look at. And the third is, do they have problems sleeping, falling asleep? They can tell me, Dr. Yu, I haven't slept for 2 days. For the last 2 days, I only sleep 1 or 2 hours. For the last 2 weeks, I couldn't sleep. On the other spectrum, also patients that sleep quite a bit, sleep 10 hours, 15 hours. So that could be a sign of depression too. The next question is being tired, no energy. And then the next question is, do they no appetite? I don't feel like eating. I just don't want to eat anymore. Or on the other hand, they can be overeating. So a sign of depression could be overeating. They oftentimes feel bad about themselves. They feel like they failed their family. They failed themselves. They let their family down. So these are some of the clues. And having problem concentrating. They cannot read a newspaper, cannot watch a TV show. They also feel that they're moving and speaking slower than everyone else. Or sometimes they feel really agitated, restless. They couldn't sit down. They have to keep walking. And then finally, the last question and most important question to judge how serious their depression is, we ask them, do they ever think about better off dead than living? Do they ever want to hurt themselves? So these are the common questions that we'll ask the patients and try to figure out, are they really depressed? There are some other signs and symptoms which are not under the PHQ-9 questionnaires. Patient can come in, can have stomach problem, they can have diarrhea, they feel constipated, or they feel tired, they have headaches. And all these things we have to work out, and we couldn't find an organic reason or a physical reason for these findings. And then sometimes it's going to take more than one visit to see if the patient is depressed and having these somatic symptoms from the depression.
Oh, wow. So it's very thorough. Yeah, that's really, really important. Sounds like as an internal medicine, it's a gateway to screen a patient who have, whether or not they have depression. So could you actually go through with us, how do you normally help a patient who have this kind of symptom? Any cases you would like to share?
So when a patient comes in and you have suspicions that they have depressions, then we have to make sure there's no other cause of their depression. We want to do some blood work. We want to make sure they're not vitamin deficiency. We make sure they're not having thyroid problem. And we try to determine that there's no other reason leading to a depressed mood, right? Then after that, then we will talk to the patient and see how much willing they might engage in medication therapy. The medicine that we use for the last 10, 15 years, they're very safe and they're very effective medicine. Unlike in the old days, we pretty much give them tranquilizer, but nowadays we don't. We give them something we call serotonin uptake inhibitor, we call SSRI, and these medicine work pretty well. Unfortunately, these medicine work very slowly, meaning they don't work right away. Patient might not take a pill and a few days later, they feel like, wow, everything is great, right? These medicine will take up to about 3 to 4 weeks before we see some effect. And therefore, a lot of the patients who we started on medicine, they discontinued the medicine within days because they felt that it didn't help them. So we oftentimes want to bring the patient back after we start medicine a month later and try to see how well they're doing with the medicine. And then from that point on, we try to encourage them to continue the medicine. We probably see benefit in about average about 3 months. And oftentimes we like to keep them on the medicine, even though when they start feeling better, back normal, we like to keep it for another 3 to 6 months to make sure they don't have relapse. And there are patients that are partially respond or not responding to medication. Then we're gonna consider referring to our colleagues, either a psychologist or psychotherapist, or to a psychiatrist for psychotherapy along with medication management.
Oh, that's good. Yeah, thank you for telling us about how you work as a team to help a patient by referring or self-manage patient. Could you actually tell us how many types of depression out there, and as internal medicine, what kind of depression you would treat actively, and what type of depression you will likely to refer, and how you coordinate to ensure the patient do well in the future?
Yeah, when a patient comes in, the first thing we want to determine how serious this patient depressive mood is, depression. If they are suicidal, if they are something that they might hurt themselves or they might hurt others. These are the patients we do not want them to leave our office. These are the patients we try to get hold of their family member, and we try to send them to a psychiatric emergency over at UCSF. Or we try to get hold of a psychiatrist right away and to see how further manage these patients, because these patients can concern that they might hurt themselves. They might even commit suicide. So those are the most serious cases, and we really need to act on it quickly. For other patients, again, if they're not severe, we definitely can monitor them closely. Definitely, we cannot start them on the medicine and then tell them to come back 6 months later. We want to kind of closely follow them. And then for those that are not responding, as I mentioned earlier, we will refer them to a psychiatrist or psychologist. And that's when you mention how many types of depression. Now, this is really by definition, my definition may be different from a psychiatrist's definition, but in my experience, I kind of put together a little table for myself. In my experience, I think a patient can have 3 types of depression. The first one is, I call it situational depression. Well, situational depression are very common. It's about 15 to 20% of our population will have situational depression. And in my opinion, everybody will have some time in their life have situational depression. I definitely do myself. When I flunked my exam, I was depressed. I can be depressed for days not eating because I felt so stupid and flunking my exam. So situation is due to a situation, and definitely nowadays in 2019, 2020, and even 2021, we have a major pandemic, right? So a lot of people are depressed for many reasons. Loss of job, being jailed at home, right? Shelter in place at home, not able to socialize with friends, not able to go out to a nice restaurant. So these can all lead to situation depression and losing a loved one, losing jobs, ending a long-term relationship. These are all situational depression. And the second one is physiological depression. It's not as common, I think. It's about probably 5 to 6% of the population. These are usually due to a physiological reason, such as hormonal imbalance. Women who have their reproductive hormone changes, we have something called PMS. Those can cause depression over time. We see women who gave birth, we have postpartum depression. I think these are all physiological. Neurochemical imbalance, such as serotonin, as I mentioned earlier, serotonin is such an important neurohormone that control our emotion, control a lot of things. And then there are neuroepinephrine. There are also other physical disorders, such as brain tumors. There are people who, because they are depressed, because they have a tumor growing in their brain, and they are vitamin deficiency that can cause depression. And finally, the third type, these are the people who have certain personality, people who are stressful all the time, people who have anxiety disorder, people who have an unrealistic expectation, people who are always negative thinking, people who have their hope and their dreams disrupted in their job, in their career, in their family, and also people who have very low self-esteem. So these are, I labeled this as more psychological depression. And again, there's no one group of people with one depression. I think these depression can be intertwined and come together. That means somebody may have situational depression. At the same time, they have certain personality that can cause psychological depression. And now they have some sort of hormone imbalance. When all 3 depression come together, almost like 3 circles merge together, and the circle that overlap, we call clinical depression, which another term is major depressive disorder. These patients will be affecting the feeling, their thinking, and the activities of their daily living. They have no motivation to do things. They don't enjoy anything in life. And the duration usually is at least 2 weeks or longer. And I classify these patients as being clinical depressed. These are the patients that need to seek help, and we have to identify in terms of starting on treatment or referring to psychotherapists or psychiatrists.
So were you able to talk about when they actually fall into a clinical depression, how will you actually treat them? Like, what do you have in your experience? What is most effective?
I think the one is to try to identify or understand the underlying cause of the depressions, right? And unfortunately, a lot of patients, especially I think in the Asian population, they don't open up because they quote unquote depression is not a good thing. So they don't want their family to know they're depressed, or they don't want anyone to know they're depressed. So they usually open up. And once a patient open up, because they're overwhelming emotion, they'll be crying in the office. So you know they are just are so depressed, and mood are so incredible burden to them. And these are the patients you try to help them and tell them, we can begin medicine to help you feel better. At the same time, we can solve the problem that caused you into this situation. And so usually, again, it's going to take, for those patients who doesn't open up, it's going to take a little bit longer to be able for us to help them. And when we talk about clinical depression, I also divided it into three different types. There are some that are persistently depressed. These are the patients that are depressed for 2 years, but not all the time. They come and go, meaning there's certain situation they become very depressed, and other time they are less depressed. And this can linger on for years. They are wax and wane. And these patients probably end up in long-term therapy and need to fall by our colleagues as psychologists and psychiatrists for long-term basis. And there's another clinical depression due to seasonal depression, or I think most psychiatrists will call it seasonal affective disorder. These are the ones that are usually worse in the winter months. Why? Because there's no sunlight. They seem to do better when there's natural sunlight. And there's certain cities that are always overcast. We seem to see more of these patients being diagnosed. They're usually very socially withdrawn. They're very lonely. Sometimes they oversleep, and sometimes they overeat and they gain weight or whatnot. They're very inactive. And then finally, we see some clinical depression. We have psychotic feature. These are the ones that are, I would say, most serious and definitely need our psychiatrists to intervene. These are the ones who have delusional thoughts. They have episode of psychosis, and they have visual and auditory hallucinations that need to be dealt with. I actually dealt with one patient who she's in her 80s, and a daughter called me urgently on the phone and say that her 80-some-year-old mom was chasing after her with a cleaver at home, and she locked herself in the room. I told her to call 911. This patient had a major depression with psychotic episode, and they have to bring her into psychotic emergency room. So those are the most serious out of all the clinical depression that I've seen.
Oh, wow. So in closing, so what would you like others to do in order to prevent the depression or manage or prevent depression? Is any closing words that you want to advise to others?
So basically, I call it self-help. Self-help, how do we help ourselves? We can't avoid situation, right? This situation will come to us no matter what. We can't hide our head in the hole. So this is the world that we're facing. And, not just that, with the pandemic, now with the Asian hate crimes in our Asian population, we're seeing even more of these staying home and depressed. So what can be self-help? Number one, exercise. I'm going to focus on exercise. Cardiovascular exercise is so important, especially for the younger population who can do so. We know when we exercise, cardiovascular, when we're on a treadmill, when we're running, when we're doing aerobics or whatnot, our body produces endorphin or substance P. And most researchers will say these chemicals that our body produces can lower stress, can lower depression. Actually, they did study to do that. So this is what we can do. In time of stress, in time of situation, we need to exercise. We need to force out to exercise. Sleep is very important. If you have lack of sleep, like what I did, I slept 3 hours yesterday. If I do that all the time, then you're gonna end up, when depressed situation come, you're much more difficult to handle because again, serotonin is affected by our brain. When you lack of sleep, there might be some serotonin uptake problem or whatnot, and therefore it can cause you to be depressed. Healthy diet, we know that, not just good for our diabetes, hypertension, also good for our mind. So I think we need to stay healthy. And most important, do not drink alcohol. People sometimes think alcohol can solve all problems, right? Actually, it's not. Alcohol is a depressant. It's a depressant. It will cause you even more depressed. So these are the things I think: healthy lifestyle, exercise, sleep regularly, and healthy diet, and avoid drinking too much alcohol.
Thank you so much, Dr. Yu, for giving us such a valuable lesson, so that I hope that everyone can stay healthy emotionally and physically. And please like this video and share this video if you like, even comment this video. So hope to see you next time. Hope to see Dr. Yu next time as well. Thank you.
Thank you. Thank you.
Bye.